Good afternoon and welcome to the CAQH webinar, Improving Provider Directory Accuracy. My name is Karen Waller. I am the Communications and Marketing Director for CAQH and will be the moderator for today's webinar. Before we get started, I'd like to review some housekeeping details for all those listening today. Today's session is being recorded and you will receive a link via email to the on-demand webinar that you may share with others. Both the recorded webinar and the slide presentation will be posted tomorrow on the caqh.org website. Your phones will be muted throughout the webinar today. All questions should be submitted online, and we do welcome your question. You may ask your question at any time throughout the session. Simply type your question into the right side of the GoToWebinar panel. We'll address your questions at the end of today's presentation. Now, I'd like to introduce today's presenters. They are Bruce Thompson, Vice President of Provider Data Strategy at UnitedHealthcare, and also Ann Brisk, Director at CAQH. We also have with us Ron Ursong, Product Manager, who is available to address any technical questions during the part of the conversation at the end when we're taking Q&A. Now I'll turn the presentation over to Ann. Ann?
Great. Thank you, Karen. Bruce and I are excited to talk to everyone today to give you a little more information about what we've been experiencing to date as we've launched a new directory maintenance solution here at CAQH, and Bruce will be specifically talking about their experience working with our solution and just in general dealing with the new regulations that started earlier this year. So first of all, I'd like to start with a little bit more, just a quick overview about CAQH. Many of you may be familiar with CAQH, but just in case, I'll cover it. We are a nonprofit alliance, essentially made up mostly of health plans that come together to collaborate and innovate in order to transform the healthcare industry and business processes. So that's kind of a different approach to things, but essentially what it means is we really come together as an industry to help to deliver actual solutions that can drive down administrative costs in the healthcare industry. In particular, on the next slide, these are the organizations that actually sit on the CAQH board, and obviously you can see they represent both national and regional health plan type organizations that are focused on making the system better through collaboration. So these organizations not only determine what it is that we focus on, but they also often participate, and you'll see that later as we talk about the new directory maintenance solution as well. In terms of the initiatives that CAQH actually runs, there are a number, some of which you may be familiar with already. Probably the part of CAQH that's most known is CAQH Core, which is actually how we bring the industry together to help develop operating rules for data and information exchange in the industry. We also actually do run a number of solutions, specific product-based solutions for the industry that again help really drive and focus on administrative savings for administrative processes. So in particular, some of the examples of these are COB Smart, and that one is focused on actually creating a national registry of member data to help identify overlapping coverage. We launched that a couple of years ago. We also have an EFT and an ERA solution that is helping to drive the adoption of ACH and moving from check-based payments to ACH payments for claims. And in addition, and we're going to talk more about this, but we've been operating our ProView solution, which is the largest database of provider data for the purpose of credentialing available in the market today. And that's actually what the directory solution is built off of. So I'll explain a little bit more about that. And then finally, the index, the CAQH index, is actually a benchmarking index that we run for health plan and provider organizations to track the adoption of electronic transactions moving from manual to electronic across the industry. That's actually available on our website today, and I encourage people to go take a look at that because we just recently released the 2015 version, and it is free to anyone that would like to use it. Okay, so now let's focus on kind of what's actually brought us to the table today. If you've been reading the headlines over the last couple of years, there's been a lot of focus on issues, especially as more consumers are starting to adopt some of the individual plans that are available in the health insurance exchange. There's starting to be a lot more focus on how accurate and up-to-date provider directories for these health plans are. And what I think everyone has been finding is that in general, and we all know as an industry, it's difficult to keep this information up to date, but now there's been a real focus on it and some of the issues that come with access as consumers try to actually go see doctors. So we know this is an important issue. There's a lot of focus on it. And essentially what all of this attention has led us to is, if you go to the next slide, really a big increase in terms of regulation. And I think this slide is a great sort of illustration of how this was barely on anyone's radar a few years ago, and now we can see just even on a taking away the federal component of it, state by state by state, legislatures are actually starting to take a look at this and draft legislation for it. So you can see a huge increase in that. And in particular, and I'll talk more about some of the specific states, I think everyone's aware that last year CMS finalized all of their regulations for especially Medicare Advantage plans and the requirements to start doing outreach to providers on a quarterly basis and maintain accurate provider directories starting in January of 2016. So that launched this year. They have released some additional suggestions that they would like for MA plans to focus on going into 2017 for machine-readable files that can be available for directories for Medicare Advantage plans, and also some additional fields that they would like for plans to be tracking for directories as well. So you can see those in terms of these additional data elements that have been added on this particular slide. So so there's been a couple of updates to that. Everyone's kind of gotten out into the market to start doing some outreach, and we're going to talk more about that. But really, CMS kind of, I think, drove the kind of lead car on the train, if you will, to really force everyone to get on board with maintaining their directories. We have also heard anecdotally from some of our plans that they are monitoring, CMS is doing some monitoring of provider directories and providing feedback to our various health plans about how accurate those actually are. So they're just doing small kind of audits where they're calling maybe about 100 or so and then giving that feedback. So we know it's starting. We're not aware of any penalties or anything very official happening yet. It's just more that the activity is starting. From a Medicaid and a CHIP perspective, they have released some guidance that will go into place about 1 year from now, that for Medicaid MCOs, they must update provider directories no later than 30 days from when they receive an update. So that's very specific and kind of basically fits what we're seeing with almost every other regulation. And then in addition, they've also added the ability to track accessibility for individuals with physical disabilities, and then also whether or not a provider has completed cultural competence training. So we're starting to get pretty specific and even broader in terms of things that need to be tracked. Again, that's at a federal level. So now let's go to some of the other organizations that are starting to step in with some additional recommendations. For NCQA accreditation for a health plan, they have proposed that health plans audit their own data for accuracy and then have plans in place to be able to improve the accuracy based on their findings. So that direction has come out and will go into effect in July of 2016. It's basically self-auditing, essentially, and then some plans that can be put in place to actually kind of correct things and improve them over time. And then, to just kind of add on to the pile, NAIC has also come out with a model law specific to really some direction for how health plans need to communicate about their provider directories to consumers. So more background information about how they created their network, how they developed tiers, how they assigned tiers. So really kind of exposing more information about the actual directories and networks that these plans have created. They seem to be focused on trying to get states to adopt those through legislation as opposed to doing anything, at a federal level or anything beyond states actually adopting it. So we know that a handful of states are looking at this and will be focused on it going forward. So finally, just to give you kind of a taste of what's happening on a state-based level, this is a number of states that have some specific legislation either proposed and or potentially becoming finalized. And I think the main message here is, first of all, if you don't have someone kind of paying attention to all the states you do business in for this specific type of legislation and requirements, you should. You really need to have your ear to the ground on this stuff. In addition, you might want to be involved as states actually go about creating some of this legislation. We've worked with a number of plans that have reached out to us about specifically the California directory requirements, which are much more vast and much more onerous even than any of the federal requirements. So we can help with some of those things. There's a lot that the health plan still has to do as far as their communication to consumers. That's often included in a lot of these requirements as well. If you have any specific questions about particular states, please feel free to send us a note, and we'd be happy to share with you what we are aware of. This is just kind of a sample of that so far. Okay, so what does this mean for all of us? And I think we've obviously seen this come into play in Q1 of this year. Basically what it means is we have a whole bunch of organizations that are conducting a lot of outreach using a lot of different methods, primarily email. There's been a lot of faxing still going on, phone calls, provider-based portals where they're doing outreach to get people to come in. But essentially, everyone collectively, starting in Q1, started doing outreach because almost everyone fits into some category of these regulations. So we've got plans doing outreach to kind of check that box and make sure they are compliant. And at the same time, we also have providers being inundated with all of these communications. Oftentimes, the providers may not even be aware of what precipitated this and why it's happening. And so there's a lot of confusion also going on. And the bottom line is we think long-term this model is kind of almost unsustainable, meaning if we continue to have this amount of outreach and types of outreach, there's just a point where providers may not be able to respond anymore just due to resource constraints. So what we're focused on is trying to determine if we can leverage existing solutions that are already in place to sort of ease the friction that's naturally going to occur with these types of regulations. And essentially what we're doing is we're leveraging an existing solution that CAQH has in place today called CAQH ProView to extend essentially the outreach and the ability for providers to update their directory information on the CAQH platform. So we'll talk more about what ProView is and essentially how it works, but we are leveraging an existing solution that's been in place for about 12 years. It is the largest solution in the industry in terms of number of participating providers that regularly come in to not only give us their information but also reattest and keep it up to date anytime it's needed for credentialing purposes. It was designed for credentialing purposes, and that being said, it really has become kind of a mainstay and something that providers rely on to communicate all of their data to all the different types of organizations that use it for credentialing and contracting. So let's take a little bit of a look at ProView since it is kind of the basis for the directory maintenance approach that we're taking. We currently have, and we actually think we'll be close to about 1.4 million providers by year end. So all different provider types that are coming into ProView, about half are what we call standard or doctors, and then the other half are sort of all the other types of providers that need to be credentialed. We have over 800 different types of organizations, not just health plans, that come in and utilize this information on whatever, in whatever time frame they need it for credentialing purposes. And that continues to grow as more and more organizations start to adopt and use kind of a standard solution for getting this type of data. Many states have actually adopted our universal application, and in general, we can meet the needs for all the states in terms of the specific state requirements for credentialing. And we have over 600 different data elements, including all of the data elements that are required for provider directories. So as I said, we've got these 600 plus data elements. So all of this data is, for the most part, for existing providers already in ProView, and that includes a wide variety of data that's specific to directory. So as you see, we're going to essentially build off of this to allow providers to come in and update and edit those specific fields for the purpose of making sure that their data is as up-to-date as possible for any patient that's trying to seek them out through a health plan. So a little bit of background now and kind of an introduction into DirectAssure. So again, it's built off of the ProView platform. We actually had, as we do for all of our CAQH solutions, a number of health plan organizations come together to actually develop this solution to meet their needs. Essentially what it does is it allows providers to see a subset of all of their ProView data that's specific to directory information so that they can review it and update it in a timely manner, and then we can get that information easily back to the health plans as often as daily, weekly, as often as it's needed, so that health plans can consume that information as it's actually coming into their system. So this is already launched, and I'm going to share more information about kind of what we've seen so far and how well it's worked. And it's important to point out the very last bullet there, this continues to be, just like ProView is, free to providers. So there's no charge to providers. This is a place they're already used to coming in and updating information, and this just kind of extends the use of ProView so that they can now update this information quickly and easily on our system. I do want to note that this has been reviewed by NCQA, and that's important. They have issued us basically a letter that says we are considered a source for directory updates, and any organization that uses us can rely on this particular letter. There is some additional requirements that would fall to the actual health plan organization, but we can help you meet the basic needs of collecting all of the information, doing both the outreach and then collecting the required information to keep your directories up to date. Okay, so now let's go into a bit more of how this actually works. There's really three primary components to DirectAssure. So first of all, the first requirement that came from the legislation was the quarterly outreach. So we do have a method in place to actually conduct the outreach, track the results of that outreach, and then provide that information back to organizations so they have an audit trail essentially that explains that they completed the outreach and what actually happened. Once providers have been contacted and they come into the system, they can view what is essentially a subset of their information. We call that the provider directory snapshot. And then they can edit the information. So this is just a small amount of information that they can quickly review and move through that process easily so that we can get those updates back to the health plans through, as I said, that daily or weekly report that we can send back with any changes that have been made once the provider basically completes the process on our system. In terms of the process from a health plan organization perspective, it works a lot like ProView. So organizations will identify who they would like us to do outreach for, and that may be all the same providers they credential, or it could be some additional, but either way, we'll get a separate roster essentially for that information. We will then use all of that information across all the different organizations that have rostered a provider to conduct the quarterly outreach. Our primary method for that so well is email. In addition, we will follow up with a phone call in order to ensure that we do get a response at least once every 6 months from a provider. And again, we log all of that outreach and provide it in a report that we send back to organizations. Again, the providers will actually see the required directory fields, and I'll show you kind of what that looks like in just a moment. These do align with the federal and state mandates that are out there today around what needs to be reviewed and updated. And then finally, we do send back the actual report containing all of the changes that were made by providers, or even if there were no changes, that they did in fact confirm their data is correct and that the health plan can use it. So in terms of outreach, as I mentioned, we are doing it basically once a quarter on behalf of all the organizations that have rostered that particular provider. So we're trying to hit them once basically on behalf of multiple organizations, and we do that through a fairly comprehensive communication that we send to them. We find that email does work really well. In our case with CAQH ProView, that is the primary outreach method, and providers are very used to responding to that. Again, so providers then go in, they must review and attest to their information to remain in a current status, and that does include the directory data if they have been rostered. So we actually kind of force them to go through this process. We don't want them to have kind of the option of not doing it, so we force them to go through the process. And then if the provider is in a non-current state, or if we're unable to reach them through email, we do again follow up with a phone call and try to actually find them, make sure that we explain why we need their input, and then hopefully get them through the process as well. So this is actually a sample of what our communication looks like. And again, this may be the first time some of these providers have even seen any indication of CMS regulations that they're being asked to do this. Of course, all of the mandates fall on the health plans. They don't fall on the providers, so they don't have to do anything, but they certainly understand why this is important, and we want to make sure they understand that having their information up to date in directories will help them actually get patients. So that's important. And as you can see at the bottom, this is where we would list all the organizations that have rostered those providers in that particular quarter and are conducting the outreach on their behalf. So this is actually what a provider would see as far as the screens themselves. And again, very first step, they're coming into ProView as they normally do. And then the new language that's on here is they click here to view your provider directory snapshot. So they've been rostered, they click there, they review, and they can edit the data that's specific to the directory snapshot. And we have more information about all the fields that are available. But this essentially gathers all the critical information we need. They can edit it, and that's editing all their data in CAQH ProView. And then, once they're done editing it, they will actually click a box that says they have reviewed the information, and then that allows them to reattest essentially to all of their data in ProView. So this is where we force the provider to go through those steps and make sure that they do complete this. Once this is done, then we can actually send all of the updated information to any of the plans that have rostered that provider. So we will continue sending regular files that show all the new providers that have come in and completed this process. And these files come, there's basically two kind of standard reports that we send out. I'll start on the bottom. The outreach compliance report, as I mentioned, is very specific to basically the audit trail for everyone that we've done outreach for in a quarter that you've rostered, as well as the outcome of that outreach. That includes phone calls and other methods of communication. And as far as the data that we get back from the providers, that is sent in the daily or weekly extract that we send through to an organization. And then that data can be taken and compared to what the health plan is actually showing in their system. We will also show both the old values that we had in ProView as well as the new values so they can see what actually changed. So the good news is this actually launched. And we actually did a kind of a soft launch in late 2015 to make sure everything worked properly. And then starting in late January 2016, all of these organizations across the top, these 9 organizations went live. And then we've continued to have new organizations join. And today we are doing outreach for just about 20 different organizations across the country, all different types. As you can see, we have some vision plans as well. We're doing behavioral. So we're reaching out to all different types of providers that are in the system, representing kind of a large, number and size of organizations. This particular sheet kind of shows what our success has been to date. And so we've already done outreach to over 600,000 providers between Q1 and Q2. So we're continuing to move through Q2 as we speak. This is, as I said, for the most part, this has been emails that we have sent. And when we measure essentially the response rate over 90 days, so we want to kind of look at about a 90-day period to determine if a provider will respond or not, we're seeing about a 72% rate as far as providers confirming their data within that 90-day period. If you know anything about general email outreach, that's almost unheard of to get that kind of response rate. And the good news is it validates what we believe to be true during the soft launch and the pilot that we did, which is providers are engaged with the ProView system, and they're very responsive when we reach out for these types of purposes. We also did some, we ran a provider survey, so we wanted to determine kind of what their experience was. And in general, we got very good responses as far as at least the ease of using the system. And it very much kind of follows their experience of using ProView, which is, that they're very familiar with it. In terms of what we're seeing them update, not a big surprise that kind of the #1 driver is their practice address. So this is the type of information that sometimes they would let lag for various reasons, and that everyone's very focused. And it is important to understand, no matter how much outreach you do, what's most important is, are you getting good, accurate, updated information to keep putting back into your system to keep publishing? So, that's kind of really where the rubber meets the road. We are seeing a high number of changes to practice addresses, also removal of old practice addresses they may have had in the system and never removed. So again, this snapshot's allowing them to quickly focus on that, make those changes, and send it back. The other area where we think, so we do expect, I should mention, we do expect addresses to kind of start to decrease over time as far as changes, because we believe that this big cleanup that's happening in these first few quarters should help to address a lot of the providers that just haven't kept that information up to date. And then over time, we actually think what we'll continue to see change maybe a little more often would be accepting new patients. So you could see changes quarter to quarter. Maybe as an organization gets enough Medicaid patients, they might say we're going to stop taking new Medicaid patients for a while. So we do think there's going to continue to be some fields that change a little more frequently, and then we should start to see a slope as far as some of the other fields that they just had not been updating before. So bottom line is, this is up and running. You can see pretty significant numbers as far as outreach that we've done, maybe close to about half of the provider population in the country. We're definitely seeing the changes come back, and we are, we're getting that information back to the health plan so that they can start to digest it. And now I'm going to actually turn it over to Bruce to talk a little bit more about his experience using it, and in general, United's experience of having to do this more broadly for all of their business.
Great, thank you very much. My name is Bruce Thompson with UnitedHealthcare, and I am happy to be here this morning to speak towards how we're working with CAQH and how we're ingesting the information from the validation process. So a little bit about UnitedHealthcare. So we have UnitedHealthcare, which is the delivery system of UnitedHealth Group, and then we have Optum, which is our creative and technology solutions portion. We cover all lines of business, both onshore and internationally. On the next slide. So just kind of at a glance, we are currently making a difference in 47 million people's lives. We have 10 million new members that are added organically in the past 6 years, over 200,000 employers, but 1.6 million Medicaid members added since 2013, about 3 million active duty and retired military that are served. And as I mentioned earlier, it's not just the United States. We do business in 125 countries. So very pleased to be a part of UnitedHealthcare. We, like most of everyone on the call, regardless of the size of your company, is working through the mutual challenge of how to improve the provider data experience. And I've done this for, gosh, probably about 23 years with different companies, and I can tell you that never has the pressure been on at this level to make a difference and get it right. I think that we now are in the best position that we have been in a long time to actually get the support that we need to make the difference. The directory challenges that we face, again, are much like yours, right? So we are reliant upon a reactive situation. So in years past, we've relied upon a provider notifying us that an address has changed, and then it's kind of up to us and you all, right, to figure out, so what does that mean in our systems? Specifically, what does it mean for that provider, and how does it interact with the other addresses and tax ID numbers that the provider may have? So, we've participated with CAQH for many years from a credentialing perspective, and what we found as the credentialing arm of CAQH grew, that they became this industry expert, the industry source, a very trusted partner to the providers themselves. I really have no doubt that the data quality arm of CAQH will do the same. So we are, we're happy to partner, happy to be a part of it from the beginning, and I really think that as we continue to grow and as things evolve, that we're going to see, we're going to see the providers migrating to CAQH as the same trusted source that they do for the credentialing. For us, the challenges are, we have multiple platforms. I'm sure a lot of you do as well, and we are, challenged to get information from multiple sources. So we're looking forward to, the continued partnership with CAQH as a source for the data. We found, we do have a large outbound call center. What we're finding, especially after this year, to be honest with you, is we are finding a lot of provider abrasion. So I'm sure many of you on the call, as a result of the regulatory changes that went into effect in January, started outreaching to providers in some manner, whether it was email, fax, or phone calls. And even in the short few months since it's gone live, we're hearing loud and clear from the providers that it's too much. So I think that will help us to get to a unified. And then also, when you're making the outbound calls, you're reliant upon who answers the phone. One of the things I think is a unique feature that CAQH brings to the table is, normally you're going to have 1, 2, 3 people that routinely go into the portal and make the changes. So they have that relationship with CAQH and with the portal itself, as opposed to whoever answers the phone when you're calling. Now, that's not to say that many times you don't get to the right person. It does happen, but it's more of the person who has the data updating it on their terms versus your phone call outreaching to them. We struggle with third-party sources, as I'm sure most of you do. It's difficult to find the source of truth. If there were a single source of truth, then probably we wouldn't be having all of these conversations, and certainly wouldn't have the CMS regulations. It is complicated. I'm sure you guys feel probably like I do. I hear from above, it's an address. Why can't we get the address right? It's so simple, and I'm sure you chuckle as I do. There's nothing simple about it. If it were a one-to-one match, absolutely, but it's the multiple interactions that really get us. And so I think that's someplace that we're going to see benefit from the CAQH solution as well in ProView. Again, so I got out of order with my slides. You should expect nothing else from me. We have a long-term relationship with CAQH. I do think that the reputation that CAQH has means a lot. As we've gone through our CMS monitoring, we've struggled to make outreach calls and to get the same information that CMS is has obtained during the monitoring event. And a lot of it is because CMS is an established name. So if you say, I'm calling on behalf of CMS, that carries weight. I think the same thing to an extent is with CAQH, right? So they carry weight from their reputation in the industry. And so we're looking forward to, we're using the data as a tool right now. We are making some proof of concept outbound calls, some fax outreaches, and we're seeing really positive results. And to the extent that there are addresses that we have in our system that are not on ProView, we're going the extra step and recommending that the providers actually go in and load that into ProView, because it's, from a data integrity perspective, it's new to the providers as well. Many of them have used the ProView solution for years for credentialing purposes. We do think that the CAQH solution, it will be cost effective. So it's, obviously, if we can get the providers to log on, update, and attest to the data on a quarterly basis, and then be able to consume that, so not only is it going to be less expensive than us doing it independently, it's going to be easier for the providers in the long run. And I really think that's going to improve not only the provider experience, but the consumer experience. And at the end of the day, that's why we're here, right? I mean, we want to make sure that the members are able to access the providers that are part of our health plans, and that's our goal. So expected results, I will say it's still new, right? So we're still anticipating and working through exactly what it's going to mean to us. We absolutely expect that we'll make fewer outbound calls. I don't know that that's going to be immediate, but we certainly expect that over the next 12 months to 18 months time. Hopefully less than that. We're still, as I'm absolutely certain many of you are, working through the technology piece of how we're going to consume the data. We want to automate as much as possible, but we want to ensure that we're not automating something that would inadvertently skew our systems or have a negative impact to our contracts. So it's no small undertaking with the IT organizations in any organization that I've worked for in the past. It's increasing the number of providers. We want to get them to update their data on ProView. So my ask of everyone on the phone would be to the same thing that we're doing. When you do have the opportunity to interact with the providers, I would just ask that you take the time, if there's a discrepancy, to ask them to be sure to upload that onto ProView. There's no way, and some of our conversations with the doctors, they've even said, well, can you update it for me? And obviously we can't do that for a myriad of reasons, and we wouldn't want the responsibility of doing that. But I think it's that ongoing conversation, and sometimes there's aha moments. They're like, oh yeah, I'd never, I should have connected to me, but it just didn't. And so having those conversations with the providers, pushing them toward the ProView solution, I think will help us all in the long run. I think it's absolutely going to help with the quality of the data, especially to the extent that we're able to automate the data from ProView into our core systems. It's going to help with the provider accessibility score, compliance, federal, state. We're in the same boat as most of you guys are, trying to meet the state and federal regulations. And I think at the end of the day, having the data correct in our system in a timely manner is going to help our Net Promoter Score. There's not a doubt in my mind. The providers want their information accurate for directory and claims purposes. The members want the information accurate so that when they go onto our collective unique websites, that they're able to find providers without having to go through 5 or 6 tries. So our expectations of this are very big, and I unfortunately can't see who all is on the website and what organizations that you represent, but I would imagine it's from small to large, And I would bet you money that our challenges are exactly the same regardless of the size of the organization.
Thank
So
you,
kind of
Bruce.
stuff there. Yep, turn it back over and open it up for questions.
Great. Thank you, Bruce. Thank you, Anne. Now is the time during the webinar when our speakers can answer questions from our listeners. Again, please submit your questions by entering them in the question section of the panel on the right-hand side of your screen. So we've received a number of questions about the availability of both the webinar and the slide deck. You will receive an email tomorrow that will contain a link to the pre-recorded webinar, which will be available on the caqh.org website. We will also post the slide deck of this webinar, so both will be available tomorrow, and you can share that. We welcome you to share that with others in your organization as well. So we've received a number of questions over the course of the presentation. So first, Bruce, if you could answer, this is one for you. How is United deciding when you make updates based on the data that's being confirmed by the providers? Which data elements?
Right. So that's a fantastic question, and it's something that we're going through our second proof of concept with now. So we're intaking the data, comparing it to our source systems, where there's data that is that's not on the ProView roster, then we're running it through some other internal analytics based on claims submissions, et cetera, the last updates in our system. So for example, if it's an address, but it hasn't had any activity in 5 years, that would make it a higher level of higher suspect level, and then we would make outbound calls. When we complete the proof of concept, my intention is to go back to our network and business owners and say, these are the items where I think we can make automated. So, for example, if it's a fax number and there's no fax number in the system, what's the risk? I mean, we don't have anything today. Same thing with phone number. If it doesn't exist in the system today, we're better off having something there that at least somebody could reach out to. It does get trickier with the addresses. That's why we're doing the analytics behind the scenes.
Thank you very much. Another question. We've received several questions specifically about California. Does ProView include data elements supporting all of the California directory requirements? And a subset of that question, can it also support the facility site review information?
Yeah, so I think we can answer both of those questions. So so ProView today does not support facilities. So that's important. So we cannot, we're not collecting any information related to facilities. I say today because there has been consideration for it in the future. So right now it's going to be just individual providers, but of all types. So I saw a question about ancillary type providers. Again, the 1.3 million is about half standard docs, and then the other half is everybody else, all other provider types, which is a long list of those. And then the question related to California, so we have done some analysis, pretty rigorous analysis against SB 137. We do believe we have all of the data elements that are required under the legislation. There's a number of requirements that are really specific to the health plan and how they track and communicate information. Obviously, we wouldn't handle those, but as far as actually updating the directory data, we can make that available through ProView. So between ProView and DirectAssure, we can make all of that information available. So we'd be happy if anyone has specific questions related to California, you can just follow up directly, and we'd be happy to share that analysis with you.
Thank you. Is CAQH working on a solution to help address product-specific directory inclusion for providers?
That's a really good question. We've been in an iterative process of phasing in a solution like this. Right now we're capturing data around accepting new patients and accepting insurances that really at a very common level across all health plans. We have been piloting solutions to capture product-specific responses from providers, product and network specific. So this is something we're actively working with the health plans in our work group. We're collaborating with them to design the solution. We've been having multiple discussions with providers on how we can capture the best information from them and kind of streamline that process. We know that it's asking a lot of them to do that. So we're in the process of streamlining it, and we're expecting to introduce that type of functionality within the next year. No concrete timeline yet, but it's something that we're actively working on, one of our top priorities.
Thank you. Next question, a very specific one. There was a reference to different formats. When or exactly what date will the additional ASCII format be made available to health plans participating?
We're targeting June 6th, and the specifications are actually available right now. So if something that you'd like to take a peek at, let us know, and we can make that available to you even before the functionality is available.
Yeah, Karen, there's a question, Bruce, I think, that is directed to you. Specifically around, so basically the question is, how are you dealing with, when you see a change that comes from CAQH versus maybe that same provider somehow or other sent a change directly to United, how are you reconciling those, and what is your process for those?
So right now we're looking at date. We're looking at data stickiness around dates, right? So if the provider sent us information, let's say in the middle of May, and then this week we received an update from CAQH, so it's within a 30-day window. If it's an update to that specific address, we're going to question that. So things like that at this point in the game will require review, because we don't want to negatively impact a change that the provider may have sent to us and just did not make the update on ProView at this point.
Right.
Okay. Another question, is CAQH going to be able to produce directories for health plans?
Yes, the answer to that is no. We are meant to be an input to your directory updates. So we have providers validate the information they have put into our ProView system, and we give that information to you, and then you ultimately will decide what should be published. But we're basically just an input to that information.
Okay. There have been several questions regarding NIPS and the NPI registry. How do these two sources, data sources, interact? Is that all, or how do they compare?
Sure, that's a great question. So many of you know that we do capture NPIs within ProView, and for many health plans, they use that as an identifier to match providers from our system with providers in their system. So that being said, we do validate NPIs that are entered in our system against NPEs. So we will provide feedback to the provider if it's an NPI that doesn't exist, or if it's an NPI that doesn't match who they are. And we'll ask them to update it to the correct NPI. That being said, we're not, I'm wondering if the question is implying, or are we updating NPEs, or is NPEs updating us? And the answer to that is no. NPEs has a very focused mission, and that's to provide NPIs. They're a registry for NPIs. I know that there's been some discussions in the federal world about expanding that scope, but that's we're not aware of any plans for that to change in the future. So right now we are validating NPIs against NPEs, but we're not consuming any other data from NPEs.
Thank you, Ron. One question about tracking. When the CAQH staff make phone calls to provider offices, are they recording whether or not they are speaking with staff or the provider themselves? Is that information part of the compliance report?
Yeah, and I think just as a kind of precursor to answer that specific question, It's important to point out that I think we have found phone calls are pretty inefficient. They're a lot of work to actually get someone to respond and get some accurate information back. And I think that's just an important data point as we all consider how we're going to do outreach, because essentially it might be taking an office person away from a patient or submitting a claim or something else that's very important. So you want to answer the other part?
Yeah, so we're calling the phone number that the provider is giving us, actually multiple phone numbers. So they're giving us personal phone numbers, they're giving us practice location phone numbers. So it really depends on which phone number we're calling, and we'll list all the phone numbers we're calling, and then in the notes section of our outreach compliance report, we'll provide some extra context around that. But we don't have a specific column for the individual's name that we're reaching out to. We do have the phone numbers that we're reaching out to, and then the timestamp, and then any other relevant details to that.
What percentage of providers within the system do not have email, and how do you do outreach to them?
So to participate in CAQH ProView and DirectAssure, providers need to have an email address. And upon registering their account with us, we have to validate that it's a functional email address. We'll send them a link. They'll have to click on it to demonstrate that the email address works. So 100% of providers have email addresses within the system.
When DirectAssure, when you get a response from the provider updating and attesting to their information, how does that data get to a health plan? And then does CAQH itself attest to the accuracy of that data?
Sure. So as far as the outputs that we make available to the health plans, right now, it's mentioned in the slide deck, but right now we have the XML format, and then very soon, in a couple of weeks, we're going to have the ASCII flat file format. So those are the two different flavors of data, if you will, that you can consume. And the health plans would consume that by bringing it into their system, into some type of workflow system for review and update. As far as attestation, CAQH isn't attesting to the data. The provider themselves are attesting to the data. Every time the provider makes an update to the system, and every time that data is made available to the health plans, the provider has to attest to the accuracy of the information.
So, Bruce, we had a question regarding, and I think maybe you could at least give us your interpretation of when the 30-day clock starts on receiving a change from a provider, and when you have to get it into the system. I don't know if they were very specific about that in terms of the regulation itself, but do you, what is your take on that?
So I'm going to tell you my take as it relates to CAQH. I believe that once you will be relying on the quarterly attestation from CAQH, in my opinion, and this is not, that's all it is, my personal opinion, right, is that you're really deeming CAQH as like an arm of your organization. And so my interpretation of how CMS would say is, well, if CAQH is going to be your quarterly attestation, then your clock starts the minute that the provider has updated information in the CAQH system. And so the 30 days would begin from the time they update and attest to the information in ProView until the time it appears in your online directory.
Thank you, Bruce. And as a follow-up, probably to Ann or Ron, has CMS sent a similar letter as that sent by NCQA that recognizes this DirectAssure process for provider directory accuracy?
So we're not aware that CMS has endorsed any solution, hasn't endorsed CAQH. We believe that CMS is trying to remain as kind of an objective third party in the mix as much as they can. Well, we have been having ongoing dialogues with CMS, in particular within the Medicare Advantage group, and with the purpose of aligning our initiatives and letting them know and updating them with our progress and what our solution does. So we do have an open channel for communication there, but we don't believe any vendor has received any type of endorsement from CMS related to this.
Okay. One more question, Bruce, that someone asked regarding, this is kind of an interesting question, I think. Are you at all planning on trying to change your provider contracts to potentially sort of impose even maybe penalties or put some sort of language in there that says they have to provide you with updated information? Has that been a consideration?
It has been a consideration that we're working through all of the details right now, and I don't have all the specifics around it, but we're absolutely looking into what we would consider egregious non-attestation and the possibilities of how that could impact claims reimbursement.
So I guess just to piggyback off of that, we know that there are other health plans who are imposing penalties and some actually introducing incentives as well for up-to-date data.
Another question, what do you do if the provider isn't currently participating in CAQH ProView?
Yeah, so as health plans roster providers, and if they're, so just to be clear, the vast majority of providers that you're going to try to roster in CAQH ProView are already going to be there, and their data is already entered into the system. So I think you're going to be able to expect that from the vast majority of providers, but for those who may not yet be participating in ProView, the way the rostering process works is that you as a health plan would be providing us, CAQH, with a list of identifiers, so kind of your usual suspects, your NPIs, DEA numbers, names, dates of birth, and your primary practice name. We use that information, see if the provider is in ProView. If they're not in ProView, we'll take the contact information you provided. So that's either a mailing address or an email address. We very much prefer email addresses. We get a lot more traction, a lot more responses on email. We'll reach out to them and give them an invitation to participate in ProView and provide them with all the explanation for what the information is going to be used for. So we will do outreach and try to get them into the system and try to get them to participate.
And Bruce, just to add on to that, for any providers that we cannot conduct outreach for since they're not in ProView, what is your process for those providers? Someone asked that question.
We actually have a provider verification outreach organization. So we would outreach to the providers via fax or phone call if they're not participating in the ProView solution. We also have a web link portal, which is in the process of being deployed, by which providers would be able to log on and attest.
So a question came about what specifically we mean when we're talking about providers. Is it only MDs, or are allied health professionals also included? And then what about facilities such as home health, hospice?
Yeah, so it's absolutely inclusive of all the standard provider types. So MDs, DOs, chiropractors, dentists, but also allied provider types, physician assistants, nurse practitioners, even some of these new emerging provider types like genetic counselors and athletic trainers. It's not inclusive of facility or institutional providers. That's as Ann had mentioned, that's something that we're considering for the future.
Next slide, please. So thank you. We've come to the end of our webinar. Thank you so much for joining us. If you have additional questions, we were not able to get to all the questions today, but please follow up on email for sales@caqh.org. Again, this webinar and the slide deck will be posted on our website in the DirectAssure section of caqh.org, and there's also a great deal of additional information about the solution. Thank you again for participating today.